Meds Explained starts with one fact. Metformin lowers liver sugar, while Jardiance and Pioglitazone sends sugar into urine. Ozempic, semaglutide, can slow stomach emptying, and insulin replaces a missing hormone. These medicines all lower blood sugar, but they do not solve the same problem. The best choice matches the main driver, not the newest injection. The same A1C, a 3-month sugar average, can need different tools. Many people imagine diabetes medicine as one ladder. Start mild, move stronger, then end with insulin. That picture is too simple. Diabetes is a traffic problem involving the liver, muscle, fat tissue, gut, pancreas, kidneys, and daily food choices. Two people can have the same sugar average and still need different medicines. One needs less liver sugar overnight, another needs weight loss or kidney protection. The prescription makes sense only after the target is clear. I'm Dr. Kim, a licensed physician. This is not medical advice. Consult your doctor. Blood sugar rises after carbohydrates become glucose, the main sugar in your blood. Insulin is the hormone that moves glucose from blood into cells. In type 2 diabetes, the body resists that hormone. Later, the pancreas may also make less of it. Metformin usually targets the liver first. The liver releases stored sugar between meals and overnight. Metformin helps reduce that extra release and can improve insulin response. It usually does not cause much weight gain or loss. The older drug is not automatically the weaker idea. Metformin can look boring beside newer medicines, yet it often fits the actual problem. A quiet overnight sugar leak may need a liver-focused medicine more than a medicine chosen only because it looks newer. Another older approach pushes the pancreas harder. Sulfonylureas, such as glipizide or glympyride, tell the pancreas to release more insulin. Blood sugar can fall quickly. The push can continue after a meal has passed, so low blood sugar and weight gain can happen. A different pill aims at insulin resistance instead. Pioglitazone helps the body respond better to insulin, especially when resistance is the main problem. The concern is fluid retention, meaning the body may hold extra water. That matters most in people with heart failure risk. Other pills work through gut signals after meals. Januvia, sitagliptin, belongs to a drug group called DPP-4 inhibitors. This group protects helpful gut signals after food. The effect is usually modest, so it rarely fixes severe diabetes alone. That makes these pills different from newer injections that copy natural gut signals after eating. A gentle pill may help when the goal is small improvement. Hypoglycemia means blood sugar falls too low. These pills have a lower risk of it. Those newer injections include Ozempic and Mounjaro. Mounjaro is tirzepatide. They work through hormone signals that start in the gut. These drugs increase insulin release mainly when sugar is high. They also reduce glucagon, a hormone that tells the liver to release sugar. They slow how fast your stomach empties and often reduce appetite. Popularity can hide the diabetes question. Is the person improving safely or just chasing weight loss? Weight loss can make a medicine look successful while the diabetes plan stays incomplete. Nausea can also stop the drug before any benefit appears. Another class works far from the gut. This class includes Jardiance and Farxiga. Farxiga is dapagliflozin. These drugs block a kidney gate that normally pulls sugar back into the blood. Instead of forcing more insulin, they let extra glucose leave through urine. These medicines can matter beyond the glucose number. For certain patients, they can protect kidneys or reduce heart failure risk. That does not make them automatic choices. Kidney function, dehydration risk, infections, and other medicines can change the decision. Heart disease, heart failure, or chronic kidney disease can change the ranking. Chronic kidney disease means long-term kidney damage or reduced filtering. In that situation, organ protection may outrank a medicine that only lowers the blood sugar number. Some patients need organ protection first. Others mainly need help with a meal spike. When the main problem is after meal sugar, slowing carbohydrate entry can fit that pattern. Acarbose slows carbohydrate breakdown in the gut, so glucose enters blood more gradually. The trade-off is gas, bloating, and a schedule tied tightly to eating. Insulin is different because it replaces a missing hormone. It does not just nudge another pathway. In type 1 diabetes, insulin is required for survival. In type 2 diabetes, it may become necessary when the pancreas cannot keep up. Basal insulin covers background needs between meals and overnight. Basal means a steady foundation. Mealtime insulin covers carbohydrates eaten at a specific meal. These are different jobs, so one insulin plan can fail when the wrong pattern is treated. Can one medicine be enough? Sometimes, yes. The real issue is not the number of medicines. The real issue is whether the drug matches the pattern. One correct tool can beat 3 poorly matched tools. Build the pattern before choosing names. Fasting sugar points toward the liver. After meal spikes point toward food timing. Kidney and heart risk can change the goal. The right medicine should match the driver before chasing a brand name. The matching approach has limits. If blood sugar is very high and weight loss, thirst, or ketones appear, the plan changes. Ketones are acids produced when the body burns fat rapidly. That situation may need urgent evaluation. A slow outpatient comparison is not enough. Once danger signs are ruled out, the visit should become practical. Ask which part of the body the drug targets. Ask how much lowering is needed. Ask whether heart or kidney disease changes the priority. Ask what side effect would make you quit. Cost and side effects are not side details. A medicine that works on paper fails if it is skipped. Nausea, low blood sugar fear, injections, urinary symptoms, and price can decide the real result. A perfect drug plan does not help if the person stops taking it. Most treatment plans are combinations, not contests. Metformin may reduce liver sugar, and this kidney-focused class may help remove sugar. A gut hormone drug may reduce appetite and after-meal rises. Insulin may cover a shortage that other drugs cannot fix. Safety also changes over time. Kidney function can decline, meals can shrink, and other medicines can be added. A drug that was reasonable last year may become risky later. Diabetes treatment needs review, not autopilot. Long-term changes are one reason to review medicines. Short-term events can confuse the picture too. Alcohol use, steroid pills, infections, and missed meals can push readings up or down. Bring these changes up early, not after several confusing dose changes. Those events explain why one isolated number can mislead. Home readings give context that a single lab cannot. Fasting numbers show overnight patterns, and after-meal numbers show food and timing patterns. Symptoms show whether the medicine is causing problems you can feel. Written numbers help because small patterns are easy to miss from memory. Bring fasting readings, after-meal readings, kidney tests, heart history, side effects, and budget. The best comparison is not a popularity chart. It means matching the medicine to the body problem, risks, cost, and daily life. Diabetes medicines are not a single ranking from weak to strong. They are tools aimed at different failures in the same glucose system. Match the drug to the driver, the risk, and the person in front of you. The best diabetes medicine solves your version of diabetes. Choosing well means matching the tool to the job, the risks, the cost, and the routine. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.